Welcome. Good evening. I'm Laura Erskine. I am the director of the Center for Healthcare Management, the director of our online MHA program, and faculty in the Department of Health Policy and Management at the Fielding School of Public Health. And I'm thrilled that you're all here to join us tonight for the Paul Torrens Health Forum. This is clearly a very popular topic. We have some very popular speakers, and so I'm looking forward to quite a robust conversation. So this session will be recorded. We will email the YouTube link to all of the registrants once it's live. It usually takes us about a week so that we can get it subtitled and transcript and everything. As many of you know, this program was named in honor of Paul Torrens. For more than 40 years, Professor Torrens guided and mentored and helped shape many of you in the room and many people throughout the country. He was very committed to this idea of creating a space for dialogue, for advancing ideas, for sharing, and he really treasured the fact that this was an event that attracts students, faculty, people in the healthcare community, alumni of the program, and so we're glad to have all of you here. I want to encourage you to use Slido to ask your questions. This QR code will appear a few times, but it does two things for us. One, it allows us to make sure that the questions can be heard, but second, you can upvote questions that other people have asked, and that will signify that that's an issue that more people are interested in talking about. So, our first speaker is the moderator of our panel. Paul Viviano is a healthcare leader, the CEO of CHLA. You can read the rest, but Paul, do you want to come up and share a few words?
Thank you, Laura, and thank you all for joining us this evening. I join in welcoming you here to the Paul Torrens Forum, and a special thanks to our panelists. We're looking forward to an interesting and timely discussion this evening. So I just have a few comments relative to kind of the macro view of advocacy and why this is so essential to all of us in our work today, and encourage you to be actively engaged throughout your entire career in public policy and in advocacy work. To state the obvious, evidence-based health policies can help prevent diseases and promote the health of the communities that we serve as providers and as community residents. So from the ACA through the pandemic, through today's challenges with mental and behavioral health needs, healthcare policy has never been more important, more urgent, and more impactful. Which brings us to this evening's content and this very timely and important discussion, current healthcare policy, the topic of tonight's discussion, impacting California's healthcare delivery system, including balancing affordability, access to care, equity, and quality of the care that's delivered. And as you'll hear tonight, government policy has enormous implications for the residents of our great state, as well as for healthcare providers and all those who we serve. We will also discuss this evening the economic and health implications of government underpayment to providers, cost shifting, differing perspectives on what drives high costs and spending in U.S. healthcare, the California Office of Healthcare Affordability's new spending limit proposal, and future public health and financial considerations for healthcare policymakers and the electorate, including two very important proposed ballot initiatives for the November election. We hope tonight that you walk away with a more holistic view and understanding how government policies come to impact the health of the community, our patients, clinicians, and again, all of those who we serve in the community. So with that much, we're going to introduce our first speaker, Dustin Corcoran, who is the CEO of the California Medical Association. Dustin, welcome. So before I turn the podium over to Dustin, Dustin led an incredible effort, and that was to get the MCO tax approved by the state legislature and signed by the governor, and is also one of the state ballot initiatives that I referenced earlier, also impacts the MCO. So we congratulate you for that effort and for all that you have led to make that a reality. So welcome.
Thank you, Paul. And since I'm up here individually, it feels awkward sitting, but here I am sitting before my colleagues join me. So when we had our pre-meeting, we decided that I'd go first just to tee up the conversation, particularly around the MCO tax. And I'm pretty sure that there are very few people in this room that have heard of an MCO tax or know what it is, and because it's rather obscure. But I'll give just a brief background, and then I want to get into the meaning of the MCO tax and the leveraging of those dollars for Medicaid. The state of California has had 3 preceding MCO taxes. This is the 4th. What is an MCO tax? It's a managed care organization tax. What it does, and I'll use pretty basic math because it's not exactly what that is, but let's say you tax $75 per member per month on Medicaid managed care lives, and you tax commercial lives at $1 per member per month. You take all of that money, you aggregate it, you take it up to the federal government under Medicaid rules, FMAP. That's matched by the federal government. You bring those dollars back to the state of California. You return all of the PMPM on Medicaid lives, that's $75 PMPM. The state keeps the $1 PMPM on commercial lives because there has to be a loser under federal rules, but you can convert really what is like a $60 million tax into the billions that I'm going to talk about. In those preceding taxes, like I said, all of the money went to the state general fund, none of it went to health care. After the 3rd MCO tax, the state let it lapse. A couple of us in Sacramento, most notably Jennifer Kent, the former Department of Health Care Services Director, saw an opportunity to say, well, why don't we use health care dollars for health care, particularly to address a very acute issue, which is access and equity for Medicaid patients. 1 out of every 3 Californians is on Medicaid. With the expansion under the ACA, the governor's expansion into undocumented individuals in California, 1 out of every 3 Californians. 1 out of every 2 births in the state of California is Medicaid. Yet nobody can argue with a straight face that those individuals, despite having this massive expansion that we've done, an incredibly rich benefit package, has equity in access, or to have the access that any of us demand for ourselves or for our families. It's an absolute injustice. So again, looking at that opportunity, we saw the ability to take the MCO tax and to leverage those dollars in a different way. And my cue up there is right where you stare into incredibly bright light. So I'm going to try and read through that bright light some key pieces here. And if I turn around, excuse my, let's go to the, good idea. So I don't have to sit anymore. Oh, and it's way better over here. I'm not staring, I thought I was going off into, and I can use this microphone, I thought I was going off into the heavens there with the bright light. Warning to my fellow panelists, just wait till you get up here. So this is going to happen in a few stages. And again, this is monumental. And when I say monumental, this is the largest rate increase, what I'm going to walk you through, largest rate increase in the history of the nation in Medicaid. Particularly important for California because we're like 46 in the nation in reimbursement rates. Last across the board rate increase was in 1999. So this year, 2024, this is being implemented right now. They're going to bring all primary care, obstetrics, and non-specialty behavioral health up to a minimum of 87.5% of Medicare. Now you say, well, only 87.5%? Well, some of these rates are down 60% of Medicare, so it's a big deal to come up to that floor. Now what's going to happen in 2025? This is where big numbers start to kick in. This is where the promise of access, I believe, will begin to be realized in full. For primary care, and this is on top of what's happening in 2024. It's additive. Nearly $1.4 billion additionally for primary care. Specialty care, $1.13 million. Outpatient, this is both hospital and ASCs, $490 million. Family planning and abortion, $500 to $600. Really quickly, the reason there's a range there, family planning is matched on a 9-to-1 basis. Abortion is not matched at all under the Hyde rules, so that's why that's a range. It depends how much you put in which bucket there. Clinics, these are FQHCs. Luis, my colleague, will be up talking about this, $100 million for FQHCs. Emergency departments on the hospital side, $560 million. ER docs got pulled out of the specialty bucket, so they got their own unique bucket, $200 million. Public hospitals, $150 million. Ground emergency transport, this is the private side of emergency transport, AMR, $100 million there. And then behavioral health throughput, again, a range depending where you put it. There's different matching levels. But this is to declog emergency departments, so this could be psych beds and outpatient facilities to try and get people into the proper care environment, $450 to $500 million, $150 million for non-physician workforce, and then for GME, $75 million, that's in addition to the $40 million that's in Prop 56. We're a net exporter. If there's any medical school students here, we're a net exporter of medical school graduates because we don't have enough residency programs. Then the ballot measure kicks in for 2027. The ballot measure does a couple important things. In addition to raising all of those buckets up from what I talked about earlier, it also locks it in and makes the funding permanent so that rates can't be cut because providers need to be able to depend on it, not worry about whether they'll be able to continue to care for their patient or face bankruptcy. That should not be a choice that any physician, any clinic, any hospital ever has to face or make a choice around. So it locks it in, adds, I won't go through all the numbers again in the interest of time, but also to note that the ballot measure adds a couple new categories. Affordable drugs, the governor has prioritized making our own insulin, so it puts more money into that. Community health worker grants at $32 million. Physician and dentist loan repayment at $32 million. And non-physician loan repayment at $32 million as well. Ongoing, continual funding in perpetuity as long as the MCO's around. You see the totality of this, right? Go back a slide, 6 to 6.5 billion, and then jumping up to 7.7 to 8.7 billion in the out years. This, to me, is a moment in time where we hope we can realize the promise of the ACA, equity and justice in healthcare, that every patient gets the care that they need when they need it and where they need it. And that is my very quick introduction to the MCO so we can preserve our time for what I know will be a very robust discussion on all the topics that Paul talked about. But when you start to see the campaign launch, and you'll start to see the public-facing campaign launch in July, that's the coalition that came together, not just for the ballot measure, but to get it done in Sacramento. It really took the entire healthcare community coming together and fighting for the ecosystem of where patients get their care. Hospitals, clinics, physicians, all coming together. Planned Parenthood, I have to acknowledge Jody Hicks, to acknowledge the Hospital Association, Carmela Coyle, Francisco Silva at the FQs. Everybody coming together. We don't normally do that. We did it here, and you see what can be accomplished. And I know that we're going to win this in November and provide that permanence and that certainty in healthcare. I will turn it back to Paul. Oh, no, I introduce, I suppose, Louise McCarthy, who will come up and is the president and CEO of the Community Clinic Association of Los Angeles County and one of our incredible partners on the MCO.
Here we go. If you want to sit down there so you're not in the light? Okay. There you go. All right, I kind of go around, that way I can actually see people around the podium. Thank you, Dustin, for digging in and explaining all the wonky fun that is the MCO tax. Let's just step back in time a little bit. So I run the Community Clinic Association of LA County, and 30 years ago we were founded. So it's our anniversary. And we were founded under very trying times, not times of an opportunity like this, but times when LA County was on the verge of bankruptcy. And that bankruptcy was driven by our Department of Health Services budget, which was a major deficit. And the county was looking at closing hospitals. They were closing their own outpatient clinics. And they were looking at every belt-tightening measure that they could. And lucky for us, there were some forward-thinking county supervisors, a coalition of community health centers that came together and founded our association because they said, wait a minute, we need to have a voice to think about how to turn this ship around, how to get access back. People, one in three Angelenos was indigent. No one had access. There was just a handful of health centers. And really, when you think about the health status of our communities, we were just on the brink of collapse. I love the numbers that you're talking about now, Dustin, because at that point in time, us bringing in $1 billion over 5 years was a massive, massive undertaking, and that started to turn the ship around. The county got a waiver from the federal government that doubled the dollars, so that $1 billion came in to bring us out of bankruptcy and created the foundation of access, which actually we just sunset at the end of January, our indigent care program, as we moved the last of the undocumented Angelenos under 138% of the federal poverty level onto Medi-Cal. Super exciting. You can clap at that, but why don't we do that? So as we think about those expansions in coverage, we expand coverage. We took advantage of the Affordable Care Act. We got all these folks onto Medi-Cal, onto Covered California. After that, California said, we're going to double down, we're going to put our own money in and make sure that folks without documentation can also get onto Medi-Cal. We keep on covering more folks. We also start adding more benefits. Now there's doula benefits, there's community health worker benefits, there's all of this. But the thing we haven't done, and which Dustin underscored with us, 46th in the nation, you said, is we haven't done anything about access in the form of rates for the safety net that provides services to the folks that are on these programs. And so there's 3 legs to the stool when we think about coverage, and it really is get people covered, provide them the benefits, and pay the systems to make sure they can deliver that care. So this matters especially here in LA, because for the 110 organizations across LA County that are nonprofit community health centers, they serve at around 400 sites, they serve 1.87 million Angelenos a year. 64% of those folks are on Medi-Cal. About a quarter are uninsured, and only a sliver are on Medicare or private insurance. So Medi-Cal is what drives the safety net in Los Angeles County. Medi-Cal is the payer, and if we do not invest in Medi-Cal, we lose our safety net. So that's just absolutely critical to think about. Of those 1.87 million patients seen each year, around 76,000 are experiencing homelessness. So as we think about the folks that our health centers are serving through their street medicine teams, through their backpacks and their mobile vans and their outreach, it is really about making sure that they get access not just to the primary care that we provide, but to the specialists, the hospitals, and all the other host of services that are part of the framework of the safety net, which is why I think that slide with the logos at the end is really impressive, because those aren't folks that have typically worked together. We've been fighting over scraps for decades. It's always been us against other systems to try to pick up what we can from a very lean budget times. So the fact that we're coming together for a cumulative investment in our safety net is huge. And I'll just close with the kind of the highlights of our priorities, and we'll get into this discussion with Paul and Tom. But as we think about what matters for LA in health policy, like I said, it's Medi-Cal, because that drives so much of what we do. Certainly, we also are concerned a lot with the remaining uninsured, because a lot of folks are still working poor. They're still very under-resourced and ineligible for Medi-Cal, ineligible for coverage subsidies in Covered California because of documentation status. We will get to that. We're still working towards that, but in the meantime, we're going to focus on what we can focus on with the resources we have. So investing in Medi-Cal means reducing the barriers to reimbursement. There is always a barrier to say, oh, you didn't hit this productivity standard, or, for health centers, you can only get paid when it's a face-to-face visit with a billable provider. So great community health workers are a benefit, but the health centers don't actually get paid when they provide those services, or the outreach, or the enrollment, or any of those enabling transportation, patient education, all of that stuff, that it's only when a doctor provides the visits. And we know that team-based care is the way things are going. We know it's more affordable if we're providing services and systems. We'll focus on everyone working to the top of their scope. So we want to reduce the barriers to reimbursement, reduce the barriers to providing care also, because unfortunately, we're held to a licensing standard that your average physicians aren't. It's Section 1204 of the Health and Safety Code, if anyone's looking it up. And it's in the same category as hospitals when it comes to our buildings, our HVAC systems and stuff like that. And it limits our ability to open up new sites and provide new services. Thinking about expanding and optimizing our workforce, we'll talk about that as well, but we have a shortage. The exporting of those folks who are leaving the state for residency slots, the fact that we don't have enough behavioral health providers, we don't have enough licensed clinical social workers, billers, coders, front desk, you name it. We need to invest greatly in the entire workforce of healthcare. And that's important because healthcare is the largest job growth sector for middle skill jobs in Los Angeles. So those are the jobs with high school equivalency and up. And so if you think about where opportunity happens and where we invest in our communities, it's middle skill jobs and it's healthcare. And then finally, thinking about advancing transformation. What are the ways in which we can do things new ways in which we can approach care? Telehealth. It wasn't until COVID that the state actually agreed to reimburse for telehealth services, for telemedicine. I had been getting, I thrive all day. I love my Kaiser, but I could get telehealth all the time before COVID, but Medi-Cal providers couldn't. So now we evened the score when COVID came up, and we kept it, and it's ongoing post-COVID, but we had to fight for it, for sure. So as we think about that, it's really about advancing transformation, reducing the barriers, and expanding the workforce, and investing in Medi-Cal is how that happens. So with that, I'll hand it over to my hospital colleague. Oh, it's not me? Please don't give me a clicker. Okay. Hey, there we go. Ignore the woman behind the green curtain. Okay, my next up is Tom Prisolak, the President and CEO of Cedars-Sinai Health System, which is also a major supporter of the safety net, and I just want to really recognize everything you do beyond your health system to make sure that we're all invested in, so thank you.
Thank you. Thanks, Louise, very kind. No doubt we all need to be in this together. So, good evening, everyone. The thrust, I think, of the comments I will make are more around the question of the need for the policy-making process itself that we engage in needing significant revision and change. And I'll use, for my comments, I'll use the Office of Healthcare Affordability that has recently begun operations. And I'll just use that as an example to illustrate it. But the main point I want to stress is the issue for a much different approach to thinking about how we develop policies. So I think everyone in the room, I hope many, if not everyone in the room is familiar with it, but just in the interest of time, in the interest of putting us all on the same knowledge base very quickly, the Office of Healthcare Affordability has three primary assignments. One is to review, in addition to a review that already exists by the Attorney General's office, to review healthcare transactions. That particular assignment is rooted in what I personally believe is a flawed belief about healthcare integration and the development of integrated delivery systems, and the belief that it somehow contributes unnecessarily to increased health prices. But that is part of their assignment. The second is to essentially address the issue of healthcare costs and hopefully do a better job of healthcare cost containment than has occurred thus far. And the third is to make sure that the healthcare workforce in California is adequate and is functioning and is healthy in itself. I'm going to just focus on the cost control element of it for purposes of my comments. And what I would observe is it's clear that the work of the Office of Healthcare Affordability is still a work in progress. But I would say that unless things change based on what has come forward so far, we're really just going down the path of the same flawed policy-making process that brings us to where we are. And when I say brings us to where we are, I would just make the observation that, number one, we are still dealing with the question of healthcare costs. We certainly haven't solved that particular problem. There is still a wide variety of quality in healthcare, depending on where and by whom one is being treated. You have a hospital delivery system in California in which every year, at least half of the hospitals in California are operating in the red. And if you add up the collective impact of multiple years of running in the red, you also end up with what we have, which is a significant number of hospitals who have not have and don't have the capital to make the necessary reinforcement to be able to serve the communities the way they need to. That was driven home big time during the pandemic, and it remains present today. In addition to that, I think there remain significant physician shortage or physician access problems, I should say. The observations about Medi-Cal being, I think, one of the best examples of that we've just heard. But at the same time, there are significant access problems, not just for physicians, especially for vulnerable populations, but there are significant access problems when it comes to emergency department services and inpatient hospital services throughout the state. I'm going to go out on a limb and say if we walk upstairs or exactly which direction the emergency department is here at UCLA, that there'll probably be at least 30 people who are waiting to be admitted to the hospital as we speak. And the reason they're waiting is because there's no room in the inn upstairs. That very same thing is occurring at Cedars-Sinai, and I see a number of colleagues in the room who I think could tell the very same story. The health of the delivery system, the hospital specifically the hospital delivery system in the state is not good. The current proposal from the Office of Healthcare Affordability to address the question of healthcare costs is that for the future years, the first years of operation of the agency, that total healthcare spending, and I'll come back and to define that term because it's important to understand. Total healthcare spending in the state of California not go up by more than 3%. There's often, in conversations about healthcare costs, there's oftentimes, I think, a lot of confusion and terms are misused. Not a lot of confusion around healthcare costs versus healthcare payments versus healthcare prices versus total healthcare spending. And so it's important to understand that under the current proposal, total healthcare spending, which would be the combination of the amounts paid, whether that's through the administered price systems under Medi-Cal and Medicare, plus commercial payments, and in addition to that, the impact of healthcare utilization, not just the price, but also utilization. Those two things combined under the proposal would be limited to no more than 3%. The challenge is that when you tie, and that number, by the way, again, well intended. The reasoning, as it's been described, is to try to link that number to what has been the average increase in family income in California in recent years. Again, on a certain level, conceptually, a noble idea. But at the same time, the problem with it is it ignores certain fundamental economic realities. They include the challenges associated with chronic shortages for nurses, pharmacists, and virtually every healthcare position. It ignores the reality of inflation in salaries and non-wage costs in healthcare. And remember, on the non-wage side, hospitals are places where things like the impact of technology in pharmaceuticals and technology across the board gets concentrated and delivered through the non-wage side of a hospital. So inflation and those kind of factors are ignored. It does not recognize the reality of demographics, in which the people in my generation are now turning 65, 10,000 of us turning 65 every day. And the impact that has on increased utilization. None of us get out of here alive. That may be a surprise to some people, but this is California after all, right? But the reality is the utilization, as one ages, the impact of that change in the demographics is going to be significant. It does not recognize the changes in technology. Important changes, for example, that have the potential, and it's already begun, to change cancer from a possible death sentence to a chronic disease at a cost of probably several $100,000 and in some cases more than $1 million in treatment. That technology, that technology machine continues in a very significant way. All of that adds up to an increased acuity level and the cost associated with caring for people with significantly increased acuity. And then finally, there's the issue of regulatory mandates. And so, for example, right now, in terms of the state of California, there are a significant number of hospitals who are in the midst of trying to address the requirements for new seismic requirements in 2030 at a cost statewide in California of $150 billion. And so, again, the point is that while it may be conceptually a nice idea to try to limit healthcare cost control to something unrelated, at the end of the day, there are very real factors that are driving the increase in the input cost to deliver care that at some level, at some time, must be factored into the calculation. And so with regard to the healthcare policy process, I guess what I would observe is that what's represented right now, at least in the work of the office, is that it continues a policy-making process that's based in the erroneous belief that by capping payments and prices, that somehow, miraculously, all of those underlying drivers are going to go away, rather than recognizing that, in fact, to one degree or another, those factors need to be calculated into whatever effort it is to otherwise stem the rate of increase in healthcare costs. I would just wrap up by saying, and by doing that, it really ignores the need to pursue policies that address the delivery system cost. It continues the practice of not recognizing the impact of underpayment from Medicare and Medi-Cal when it comes to the question of commercial prices. It doesn't recognize the interconnectedness of the entire system. And so today, for example, many hospitals are subsidizing physician services because if they don't, those physician services won't be available in the community, as just one example. And it doesn't consider the delivery system impacts, and it kind of approaches the question of financing kind of as an end in itself, as opposed to financing being a means to an end, which is the end being a delivery system, physicians, hospitals, skilled nursing facilities, home care services, a delivery system that can in fact deliver on the promise of what we all would like to see healthcare in California to be. And so just to close, I would just say, if we don't change the process, we're going to find ourselves pretty rapidly going down into and exacerbate some very significant problems, some of which have been described earlier. But my closing example, I guess, would be to go back to Dustin. The work that was done for the MCO tax is incredible. And Dustin and CHA and organized labor and everyone who came together to make that happen deserve incredible credit. The question I would ask from a process standpoint is, why do we need to engage in those kind of rescue efforts that are years after when the problem has arisen in order to solve the problem? And I would suggest that a more integrated policy-making process that brings together the delivery system considerations as well as the financing system will at least do better than where we have found ourselves over the years. So those are my thoughts, and I'll take my seat over here on the panel, and I think we're all going to join you from there.
As the panelists are taking their seats, I want to remind you that the Slido code is available. Capture it now, because I'm going to turn the lights, the projector light out so that it's not shining in the eyes of our panelists.
So just from a format standpoint, I've got some overarching macro questions for all of our panelists, and then I'll do some follow-up questions for them based upon the brief presentations that they made. Then we'll open it up to the audience for the Slido questions, and so please weigh in. But if you prefer to have a microphone, just let us know. We're happy to share it with you. So let's talk about some of the macro pressures. So a lot of talk about balancing affordability with access, with quality, and with equity. Given all the pressures in the environment that we face, and kind of the lead of that is the state deficit that's been projected to be tens of billions of dollars, how can we as an industry help shape public policy to address all those things in that context? So Tom, you mentioned, maybe we can start with you, you mentioned how to integrate this effort. Do you have any specific thoughts about how to integrate these advocacy efforts?
Well, this is working. The specifics, I mean, there are a lot of specifics, and we could probably spend some days designing it, but the main point I would make is that the considerations of what are the impacts on the delivery system resulting from the financing decision does not even enter the discussion. It's nowhere in the process. There's no mechanism in place. There's no group of people who are asking the questions and a group of people who are trying to answer those in the context of the decision-making process. So there are a lot smarter people than me out there who could, I think, design something, but that's the point I would emphasize.
So Dustin, I'd love to hear your thoughts about, how have providers as a community not risen to the occasion? How have our reputations not exceeded the opportunity that exists today? We don't have a great reputation. The provider community used to have a more stellar reputation. Today it's not quite as strong. How can we help recover that in order for the providers to be top of mind in these policy-making decisions that the legislature and the governor entertains?
Sure. Thank you, Paul, for the question. Surprisingly, providers still enjoy immense popular support. And I know there's a feeling particularly coming out of the pandemic and a lot of the politicization around vaccines and everything else that's taken a hit. We just came out of the field testing MCO, making sure that we were good with voters love it, by the way. So I have every confidence it'll pass in November, but physicians, nurses, healthcare providers enjoy immense bipartisan support. They are trusted messengers despite all of the rhetoric coming out of the pandemic. So that is maintained. I think what has not been maintained consistently is a willingness to set aside our differences, hospitals, physicians, clinics, others, to unify and to speak with a common voice. When it has occurred, we have not failed. We did it in Prop 56, the $2 per pack tobacco tax. It was passed back in 2016. That was a common unified voice. Hospitals, labor, physicians coming together. The MCO tax, once we unified, and we had common purpose, and we had to fight it out. And there was a lot of time sitting in the CMA headquarters with CHA and CPCA and CMA and SEIU and the whiteboard and looking at all those dollars and everything else. But once we came out unified, we were able to accomplish something nobody thought possible in Sacramento. There was precisely 0 people outside of that room that thought what I put up on the board was possible or was going to happen. So a lot of it's on us, and I think the education community has actually laid out a pathway for how to do it. They first fight for all the dollars, and then they fight with each other. In healthcare, and I've been in Sacramento a long time, and I came out of the lobbying world before I was CEO, we do an incredible job of first fighting with each other and then hoping that there's dollars. But we're fighting for scraps at that point. But look at MCO. That's the pathway forward. And when Tom lays out Office of Healthcare Affordability and other challenges that are ahead of us, if we unify, if we work out our differences, the MCO has laid a clear path of what we're able to accomplish. And again, voters trust us. So I know it doesn't feel that way. And I talk to, we represent physicians, nearly 50,000 physicians in the state of California. I tell physicians all the time, I know it may not feel like it when you're being, just beaten down every day. You're in a setting where it feels like you're not being respected and you're not being trusted. But when people leave whatever that confrontational thing is or whatever Fox News segment they happen to be watching, when they're away from that and you ask them, do you trust your physician? Yes. I trust what my physician says, and I trust that what they're telling me is the right thing to do, not just for me, but on a public policy basis too. And I think we can leverage that. You've got an initiative coming up for children's hospitals. I can tell you it's going to pull off the chart because people believe in the mission.
So it's interesting that, the nurses continue to have a fantastic reputation and are essential to this discussion. They're highly valued and highly prized as are physicians. But there is the elephant in the room, and that is that you think of these unfunded mandates. Tom referenced $150 billion for seismic requirements across the state. And organized labor has opposed the solutions that the provider community and the capital formation community have proposed. So I think there's something about the unity, and so maybe we can talk a bit about that. How we can convince all of our partners, pharmaceutical companies, manufacturers, labor unions, nursing unions, et cetera, to be part of the solution to then figure out how the money can flow later.
Yeah, I do think that's critical. I think that was directed back at me, but I do think that is critical, and seismic has bedeviled the hospitals for a long time, much like some of the issues in our world have it. CNA and SEIU are two very different unions, both very influential, both very critical to Sacramento and to the political world, and coming from slightly different points of view, but I think with SEIU, we've been able to find some critical breakthroughs. And even for CMA, we oppose the single-payer bill that's being pushed by the California Nurses Association, but I'm always trying to find something that we can work collaboratively with CNA on as well. Their former chief lobbyist is now one of our contract lobbyists. There is, at some point, commonality among providers. That whether you're part of CNA, whether you're part of SEIU and you're an RN, or whether you're an MD, you're putting hands on patients, you're taking care of people, you're putting yourself in harm's way during the pandemic, you're dealing with all the stresses of that and the emotional burden and toll that takes. There is commonality there, and I think if we can lean into that again, find that commonality, that what is it that is causing the push for single payer? What's the motivation? And I would surmise and bet that a lot of that push is for some of the same reasons that many of us came together around the MCO, which is a fundamental belief that we're trying to achieve access and equity for patients. We may differ about how we get to that end goal, but if we can at least acknowledge that there's a commonality, that providers are mostly focused on what's best for their patients, then let's talk more about what we share in common than what divides us. We may differ, again, in the outcome that we desire, but the motivation, I believe, is true. Whether it's SEIU, CNA, CMA, CPCA, or CHA, we want to see patients well cared for.
So the community clinics also play a central role in access and affordability in the community. How can your clinics help us with this integration and unification around advocacy efforts?
Well, I appreciate having gone through, and I think, Dustin, I first met you when we were in the great cuts of 2010, probably, when we were all, it was eliminating adult dental, and everyone was fighting for, again, their scraps. I think coming up on a common problem definition, and I say that seeing a professor of public policy in the room, define the problem, I see you, but before you come up with the solution, because we keep on coming up with solutions that don't actually have the problems associated. So bringing us together, and I think taking it out of the legislature was the right thing to do, because we have this challenge. We talked about all the people that love us. The Department of Finance, you didn't mention them. So funny, they seem to also be the ones pulling the strings of the Department of Healthcare Services. And we're
Not big fans of our MCO solution.
no, because it takes away, but they get a little sugar, but they're not all the sugar they want for the general fund. So when we think about, taking things out of that 1 year, 12-month state fiscal year, which is we're looking at everything in how do we balance this budget this year? For folks in primary care, we put the long and longitudinal. Your savings are not coming today. They're coming in the outrun. They're coming in the folks that we try to prevent from going to those ERs. And so getting it away from that moment in time budget and thinking about a long-term financing solution that we can take to the voters that isn't focused on just balancing the budget. That's part of the solution there. I'll also say that, we're all about coalition. That's what we do. And My members are members of CMA. Actually, my members are also located on your hospital campus, and I've got folks that have done residency at your hospital that are running my health centers also. We're all part of a family, and as long as we remember that, I think, and come back to those roots and defining the common problem, not a common enemy, but a common problem, then we can actually solve things.
So we identified one unfunded mandate, seismic. Let's talk about another one, $25 an hour minimum wage being phased in. So we'd like each of you to kind of address your thoughts about that inflation, sometimes in the context of the Office of Healthcare Affordability, sometimes just in the context of how in the world are we going to be able to afford to provide care and to find team members at that level. So Louise, maybe we can start with you.
Sure. And I'll say, first of all, we actually didn't formally oppose SB 525, the bill to put in the $25 minimum wage, but we raised a lot of concerns. And I'll say, it's not the $25 minimum wage that's the concern. A lot of health centers are already moving, actually my health center in the front row has a 25 by 25 campaign because they know they need to compete with all the other healthcare providers out in our ecosystem to be able to hire the staff that they need. But because there was also a floor for salaried employees in that bill, and it was the cost of setting this new floor at 70,000, what was it, 67,000, somewhere around there, and that as the new floor for your exempt salaried employees. And then basically anyone, you can't just set everyone at that minimum. If someone's been there for 3 years, 4 years, 5 years, they've got higher licensure, you have to cascade up and avoid compression. That was where the financial pressure really lie. But the catchphrase around the law was around a $25 minimum wage. In Los Angeles County, the rent's too damn high. We can't, I mean, no one's going to feel bad about paying someone, saying that someone deserves to get $25 an hour. So there's that. But so really coming up with the question of where do the resources come from to do this? How do we, and the MCO tax may not be the solution, it'll get resources in, but the cost pressures by and large across all of our systems are going to continue to rise. Workforce is part of that, seismic is part of that, our licensure requirements are part of that. It's a whole host of things, but bringing the resources in and coming to some sort of conclusion where we recognize that people do deserve fair wages. We just need to make sure that we can actually pay them.
So, living wage is a marvelous commitment that we all want to make and would like to make to our healthcare team members. So, Tom, maybe you can help us. Where does the compression end, and what's the impact, do you think, on the healthcare provider segment?
Yeah, so I'll come back to that in a second. I do want to return to the earlier conversation. This is for the younger people in the room that are just starting out. The message from that part of the discussion is to please keep in mind politics trumps policy every time. And I'm very serious, save yourself a lot of heartburn by believing that that's not the case. That's the reality, and I'm not being critical about that. That's how democracy works, and politics is a part of it, and being able to find common ground wherever possible is absolutely ideal. The challenge is that at any point in time, there just may not be that kind of alignment. With regard to the minimum wage, a couple of things. Number one, unfortunately, like in many situations where people, unfortunately, I think, look for simple solutions to complex problems, there was, I think, a lot of erroneous criticism of the hospital field about it. Hospitals are very much in support of the living wage and moving to that level. The discussion was really more about doing that in a way, going back to my earlier comment, of not further compromising and crippling more hospitals in California. I mean, here in Los Angeles, there have been 5 hospitals closed in the last 10 years, and there's probably 20% of the hospitals in Los Angeles that are not operating beds that they otherwise could because they literally cannot afford to pay for the additional staff in order to staff the bed, creating some of those crises and problems that I was describing earlier. So the issue from the hospital standpoint was number one, a mechanism that recognized that The reality is, in the hospital system we have today, we have a broad range of financially healthy organizations. And there are some who are able to adapt that and some who are not. With regard to the compression problem, I think that actually will vary from institution to institution, depending on the hospital, the scope of services, and the things they do. So there's not, I think, an easy answer to where the compression problem stops. But the compression issue is a very real one, because there are other individuals who work in technical positions in hospitals that understandably would ask the question, how is my job valued? And that's a very appropriate question for them to ask, and hospital leaders need to be able to respond to that in an appropriate way.
And one of the tangential questions really is, how will the Office of Healthcare Affordability view those kinds of increases that will be so inflationary? And again, it's driven by this unfunded mandate. One of the interesting parts of this is, shortly after the governor signed it, I believe he had second thoughts. He's had some conversations about repealing it or somehow reshaping it. Notwithstanding, it's the law today, and so we're going to have to pursue it. I know this will have an impact on physician practices as well.
Sure. Well, and by the way, very interesting debate at my board meeting, because the residents were quite excited about this, because they, on a salaried basis, are going to get an increase under this. So they were quite happy about it. But the conversation, and I think for a lot of the big systems, this was already in the works. It was already happening. Absorbable. They could see maybe the timeline was maybe a bit accelerated from what would have normally happened. But I had many conversations with SEIU about this. That's not necessarily true when you get out into rural communities and some of the more underserved communities. Go even the eastern part of the county, comparing the west where we are here to the east, and saying that's a singular market. To be treated the same is tough, and then going even east beyond that, when you get into the Inland Empire and the high desert, certainly this is going to be tough. And those were painful conversations, and seeing practitioners in underserved communities, particularly rural communities, think about, how can I possibly afford this? They don't have margins. They have Medicaid, 60, 70% Medicaid. That's not a margin. Maybe MCO is going to help offset that and impact that, but it's going to be very difficult for some of those practices to adapt, and because they don't have negotiating power, they don't have leverage, they don't have the ability to go back to a commercial payer and say, I need my rates changed, or to the local Medicaid plan to absorb it. And so for many physicians, it means they will take the cut to be able to stay competitive in the market, or they're going to sell their practice. And ironically, the Office of Healthcare Affordability is saying they want to prevent that. This and the office itself may frankly accelerate a lot of consolidation, simply because private practice physicians are not going to be able to absorb this into their practice in a way, and they're going to have to find a way to partner up with somebody to seek shelter from the storm. A little Bob Dylan quote for those that...
It's a young audience testimony.
I know, I lost him. I didn't name my daughter
careful.
Dylan, so spelled properly, by the way, Dylan.
So all of you mentioned supply challenges, and supply, by that I mean inadequate pipeline for physicians, nurses, and other healthcare professionals, high cost of living in California, residency slots, fellowship slots going unfilled. How do we come together to address this training gap that exists today? Because all of us as providers need more providers. Tom referenced the aging population. With that comes utilization increases, increasing complexity and acuity. The demand is increasing, and the supply for providers in the state is under enormous pressure. Let's talk about kind of what's the approach to address this. The MCO tax will have a positive impact on it. I'm not sure it will address the entire issue, but it is a start. Louise, please, we'd love to hear your thoughts.
So the first, and especially if we're talking about providers, is that we have to be, unfortunately, patient. The Kaiser Permanente School of Medicine's very first class will just graduate this year. LA Care Health Plan has their Elevating the Safety Net program, which 8 years, I don't know how many years ago, we got that kicked off with full ride scholarships for folks, 8 students a year, 4 to go to UCLA, 4 to go to Charles Drew. They're just now in residency. So these are massive investments that folks are making. Those Kaiser students are walking out with no debt. Those Elevating the Safety Net students walking out with no debt. And all of them having had experiences working in the safety net. But it takes time for them to get through. So yes, we do need to look at the provider pipeline, finding ways for the folks that are currently in. I think the GME slots is a great one because then we're not exporting the folks that we do have. But beyond that is looking at the other allied health professionals that complement the healthcare team, and that can help the folks that we do have work to the top of their scope. Because this is dental hygienists and dental assistants supporting dentists. This is medical assistants, this is physician's assistants, nurse practitioners. It is all of the above. And so I think we just need to make sure that we know it's a pipeline question, it is a recruitment question, it is a stacking credentials for folks that they can get one degree or one certificate and then work while they move up, and thinking about ways that we can be creative so it's just, there's not one solution, and every solution that we take is going to have a different time arc before we hit fruition.
So I mean, I think there are three buckets that the solution are required in order to come up with a solution. One is for the education system itself. I mean, I think like all of us, in order to deal with this, all of us who are somewhere in this process need to continually be asking ourselves, what do we need, what do I need to do to change? How do we need to change in order to help contribute? And I would make the observation that the educational community needs to look at the time, effort, and approach and cost related to educating a whole range of people in healthcare. Second, those institutions that have the resources and can, and from conversations with colleagues, I think many of us are, need to make the investment ourselves in trying to solve the problem. And so in Cedars-Sinai's case, we're starting a School of Allied Health, for example, to recognize that segment of the workforce around which there are significant, and so other institutions are doing the same thing, and I think that's part of it. And then last, and this may be the hardest because it gets back to that politics question, I think there does need to be some discussion on a policy level regarding the issues related to licensure and other kind of requirements. And while it's not, whether it may be desirable to do things like relax certain regulatory requirements, at a minimum, creating the opportunity for experimentation to examine alternatives and just getting that through in the current environment, frankly, I think would be quite challenging. But I think that's the third piece that would, I think, help.
Well, I suppose in that regard, we're the challenge, maybe, on that.
Scope of practice.
That's not what I had.
Oh, okay, all right.
That's not what no.
Now that you mentioned it.
I was wondering if we were going to get through an entire session on that.
No, that's not it.
On the workforce issue, I go back to Prop 56. That was the first time the state invested in GME. We put $40 million dedicated out of the tobacco tax into GME, and I will admit, when we were drafting it, I was very reluctant and to maybe a point of resistance about whether we should put it in or not. And I was talked into it, glad I was talked into it, because I think it proved in its implementation that money flows to the University of California contracts that to RC3 Physicians for a Healthy California, led by an incredible Lupe Alonso Diaz. You all should look up PHC, they do really amazing work. But what it showed, that $40 million when we started trying to distribute it, was we were getting 10, 15x in terms of applications for that GME money, and the 40 million proved to just be a drop in the bucket. That informed what we were talking about on MCO, so that MCO GME money that I put up there will be on top of that 40 million, and also creating permanence to the loan repayment program that was also funded out of a tobacco tax, but it only funded the loan repayment program for 5 years. Now there's a permanent connectivity there. The next step, in my view, is to create a throughput for students, where medical school deans can go recruit with intentionality, as the governor would say, he likes that word, with being intentional about who they're going after and who they're recruiting, and being able to say, look, if you come to medical school, because you're deciding whether you're going to law school or business school or what you might do, if you come to medical school, we're going to have a residency slot for you, guaranteed. when you're done with medical school. Oh, and when you're done with your residency program, if you go back and you practice in your community and you take care of Medicaid patients, at least 30%, we'll wipe out your debt. And so people at the undergraduate level can make really conscious decisions about, I want to go be a physician, or I want to be a nurse practitioner because I see a pathway to having a successful career, not coming out and, well, I hear you come out and you have $300,000 in debt, or I might have to, move to Ohio and because there's not going to be a residency slot for me there. We have to start all the way back there and put the medical school deans with the residency directors and have it all the way through. And then for the residency programs, and Luis knows this, we have to get people out of big institutions. That can't be the sole place that you're doing it. We need big academic institutions doing rotations and everything else. But you also need to go practice, if you want to, in a rural community and understand that there may not be a subspecialist down the hall to call on and to have that experience. So thinking of UC Davis up in my neck of the woods, think of everything, think of everything, all that territory above UC Davis, all the way up to the Oregon border. So how do we populate residency programs up the 5 corridor? Southern California is still hard. I say the 5, not I-5. And I get a lot of grief for that in Northern California. But how would you practice up in the northern regions of the state? Maybe come down and do a couple rotations down at UC, so you're getting enough volume and you're seeing enough of a particular case. But you're practicing in a rural community fundamentally. And then I think for a real stretch goal is taking that MCO dollars and having connectivity between an academic institution like a UC Davis and those community physicians, where they know and work together and there's a warm handoff, maybe a teleconsult, and then if the patient needs to come down, it's connected in terms of care delivery, whether that's Kaiser, whether that's Sutter or UC Davis. I see a lot of opportunity for that, but it starts with leveraging these dollars the right way, and it is the intersection of public policy and politics. But wouldn't that be so cool that a kid from rural Northern California could go to medical school, stay in California for their residency, go back to rural California, and have a thriving practice?
And I'll just mention, there is a Teaching Health Centers program, which is federally funded. There's been very limited amount of sites that have done that so far in California, but the rural areas, that's one of the places where, and in partnership with A.T. Still University, have really focused on getting those hometown scholars to be able to get these degrees, because we know that they're the ones that are most likely to go and work. Additionally, got to hand it to Davis, they do also have advanced practice training so that those folks who become physicians can get trained in psychiatry and other specialties to be able to make a difference in the fact that they don't have access to certain resources in their communities. They can get trained to be that resource.
So one more macro topic that's also a lightning rod and a contributor to the cost profile in healthcare today. Been a lot of research lately about the impact of private equity and the investments that they've made, buying practices, buying ancillary services, consolidating them, driving prices adversely to the industry. And so a lot of benefit comes with those investments, but also expectations for returns. And again, research that is driving costs up in our healthcare system at a rapid pace. Love to hear your thoughts individually about private equity and the impact that it's having on the delivery system. Dustin, would you mind going first?
Sure. So we spend a lot of time looking at this, and I'll be cautious here because you can put private equity into a really big bucket and paint it with a broad brush, and it's a disservice, but I will talk about it and try and segment it a bit, because not all private equity is bad and not all of it's the same. So I'll start with that. But we are watching the national trends. I also serve as president of the Physicians Advocacy Institute, and we did the first longitudinal tracking of physician practice acquisition across the country, and then segmenting it by region, and then ultimately by state. And the rate of acquisition is staggering. I mean, absolutely off the charts. By the time you close one survey and you open the next one back up, the numbers jump 10% or so. So private equity is moving really heavy and very quickly into the market. Depending on where you're at, they may focus on particular specialties, they may focus on certain practice size, but it's coming really fast. And And I wasn't around for it, but it feels a lot like if you go back the 80s hospital acquisition and the rapidity at which that occurred, if you look at it at that time, that it's true here. We also started doing surveys to look at physician satisfaction post-acquisition. And those numbers are alarming too. If you look at the post-acquisition attitude, and again, I'm very broad numbers. I'm not, if there's any private equity folks in the room, you may be one of the good ones, but the physician satisfaction post-acquisition is really, really poor. Physicians are really unhappy post-acquisition. Part of it is oftentimes a practice is acquired, and the senior physicians that were close to retirement, or the senior partners, get to cash out. They have a liquidity event, and they're done. And it's the mid-career physicians that are left having to make up the margin for the acquisition cost of that practice, and so satisfaction goes down. And the number one thing that drives the dissatisfaction is a sense of loss of control and loss of clinical autonomy, and the ability to be able to guide their practice. And when you look at that, you can see a bubble potentially being created here, where you're going to have 5-10 years down the road, a lot of physicians exiting those agreements and trying to find another way to practice or another home, and so there's a potential pop there. And for private equity, that may not matter. Some of them have 3, 5, 7-year event horizons. It's kind of the timeline that they work off of, and you could see that bubble potentially forming and breaking. Well, let me say, I don't think it's potential. I think it's highly likely that that's going to occur. You cannot have the dissatisfaction rates of the providers as high as they are in our surveys and not have bad outcomes or not have market disruption coming in a really big way. I think the other thing that it does is it does fuel things like the Office of Healthcare Affordability. The Attorney General is going to come out very soon with a bill that looks specifically at private equity and wanting jurisdiction over that segment of the market, much as the AG has jurisdiction now over nonprofit hospital mergers and acquisitions, trying to apply the same principles and rules there. How you define it, we'll see how they do it, but that would introduce another set of regulatory things on top of the Office of Healthcare Affordability. But it is, again, I see a bubble forming, and I don't see it ending in a good way for those physicians that were acquired, and I don't see it ending in a particularly good way for the patients that they serve, because there will be a lot of displacement if it pops all at once.
Louise?
Sure. I'm going to split this answer into two sections. One is just mergers and acquisitions, and the second, which is private equity. I'll take private equity first, which is we see that more in the drying up of resources around us for the community health centers, in the practices that are suddenly part of something else that are no longer accepting our patients, the hospitals that are no longer delivering our babies, and suddenly we're having to refer people further and further away because of that, because of those acquisitions that are happening due to private equity. On the flip side, there is a different place for mergers and acquisitions in the community health center world, which is we are seeing a number of retiring physicians, folks who are at the end of their practice and are saying, I've got these, I'm a safety net doc. And actually, I'm not that attractive to these private equity firms because they don't want my patients. And the health centers say, well, would you like to come on staff with us? And we will add your site to our health center network. And we will make this part, because we have a staff model, which is one of the features of the health center model, and which is a way we're keeping those sites open in those communities. We are keeping those folks suddenly don't have to be doing the billing and the managed care and all of that, and they're retiring in a staff capacity and seeing that their patients are being cared for in an ongoing manner. And it's so there's a different side of that in our world when you're looking at Medi-Cal practices, because when you're 46th in the nation as a payer, private equity doesn't really look at you as something to buy out. So it's a different scene.
Tom?
Yeah, well, so a couple thoughts. One, I think, Dustin accurately describes it when he says, you got to look at each one of these individually and what their intention is, to borrow that phrase from the governor, and what is their intention. Having said that, what is common to all private equity investment is return on investment. And that is the reason why, that is the business they are in. They are in the business of making acquisitions, and none of this is critical, but it is the reality. They're in the business of making investments to get the financial return at the back end, which is, Dustin accurately describes a very common scenario. The senior physicians have a liquidity moment. They get that funding for their retirement, and those who remain have to then pick up the 20% improvement in productivity that is necessary in order to begin the return on investment. And for most private equity firms, their goal is to ultimately have their own capital event at the very end when someone else is coming in to make the next investment. That's how that system works. Where private equity is problematic and where it's presenting itself problematic in the healthcare delivery space is a lot of the private equity acquisitions are focused on those physicians who have ancillary services that are involved in services that may now be done in an inpatient hospital setting or in a hospital-based outpatient setting, taking that out of that setting, and that's where a lot of the financial return comes. That is presented as a way of helping to lower healthcare costs, when in reality, it doesn't, because again, the patients that are the target of those acquisitions have a particular bias towards commercially insured patients, leaving the government-insured patients back in the hospital setting. At the end of the day, the hospital cost structure does not go down to generate what is believed to be the quote-unquote savings associated with it. So all of that is to say, back to my point earlier about the urgent need for a much more holistic policy-making environment to be able to assess all of these things that are going on. The world moves very quickly. It's moving more quickly every day, and we just need a mechanism to be able to keep up with the pace of change that understandably we're all experiencing.
And I would just, as a final thought to add on to what Tom said, we do need to rethink our policy as it relates to payments. What kind of world is it that the only entities that can make money off of physician practice don't include physicians themselves? I can talk about that at our board. Physicians cannot own a practice and be successful, yet somebody can come in and buy them up, and they can be successful owning a physician practice. The physician themselves that is generating that revenue and the ability for private equity to make money off of it. Private equity is not providing a service, they're not writing prescriptions, they're not ordering tests, they're not doing any of that. It's the physician themselves. So what is it in our policy structure that has created a construct where physicians themselves cannot have a successful practice and have equity in their own practice, much like they could have in the old days? I'm not suggesting we go back to mom and pop and that's the right answer, but it is just rather stunning and staggering that we've put physicians in a place where they are viewed as cogs or workers to the benefit of others in the system. And that may work in some settings, but that doesn't work in a lot of communities like Medicaid communities and underserved communities. That just fundamentally doesn't work, and we have to rethink our approach to that.
Laura, we'll turn it over to you for questions from the
So
audience.
I'm going to bring up the most popular question first, because I think it's got a pretty quick answer. Is the MCO tax on the average taxpayer or on health systems, health plans?
So the MCO tax is on health plans. It won't impact taxpayers whatsoever. It won't impact premiums whatsoever. We had to do a big study about that to make sure we were wading into safe territory. You're really taking what's not even a rounding error from a premium point of view, health plan point of view. What you're really doing is you're bringing federal dollars back to California. It's fundamentally what the MCO is. And you won't hear us talk about MCO tax when we get in a campaign. We're talking about access to care. You won't ever hear me say MCO because nobody knows what it is. You won't hear tax because it's not really a tax. We are leveraging healthcare dollars to return our federal tax dollars back to California. We are a net contributor to all the other states. California sends more in taxes to the federal government than we get back. Other states get the largesse of what we send. What we are doing is getting just a bit of that, and I mean a bit of it, back here to invest in our own healthcare system. So it doesn't impact California taxpayers. It doesn't impact premiums at all. not a single dollar.
Paul, you might be able to address this question. There's a question about, can you talk more about the CSS ballot initiative?
So the California Children's Hospital Association is comprised of 8 children's hospitals, is sponsoring a ballot initiative for the November election, along with the MCO tax. Hopefully, both of them will be on the ballot. So this is to strengthen the CCS program, the California Children's Services Program, which is comprised of about 250,000 of the most severely ill children in the state. And there are 122 hospitals that provide services in addition to the children's hospitals to these severely ill children. So you have to get qualified to have a CCS center. Again, about 122 hospitals altogether. So the initiative is to improve access to care for these CCS beneficiaries. So that includes eligibility requirements being strengthened, eligibility processes being improved, reimbursement to physician providers in that system to bring physicians who are providing care to these severely ill children up to 100% of Medicare rates, and also to reimburse hospitals more adequately for this, for the care that they provide to the CCS patients. The last component of that, there's a final component, and that is there are a lot of very high-cost drugs that severely ill children need in order to be cured and treated. This bill also requires that the state would pay for the cost of those pharmaceuticals, not a margin to the providers, not to the physicians or to the hospitals, but pay for the basic cost of those pharmaceuticals. And so we're in the signature gathering phase. We anticipate that will be completed relatively soon. And there'll be a small campaign to get the electorate to consider this ballot initiative. We don't anticipate any opposition that will be funded from any sources, and hope that it will gain the support of the citizens of California to care for these severely ill children. So that's a 2-minute summary of the CCS ballot initiative that we're looking forward to having on the ballot in November.
Thank you. This is a classic question that comes up each time we talk about healthcare policy, and this is, do you feel that the shift to universal healthcare is something that could ever be realistically implemented, even on just the California state level?
I assume the question's about single payer?
I'm imagining, yeah.
Yeah, because we're pretty much to universal healthcare now. We just expanded Medicaid to adult undocumented individuals in the state of California. So everybody has a pathway to coverage. So we have universal coverage. So I'm going to interpret the question not to be universal system, which we've patched together between commercial, Medicare, Medicaid, and all the different things, but single payer. No. 0% chance it's going to happen here in the state of California, and I'm not, you may take it flippantly, it is not possible for a state, even as big as the state of California, to implement a single payer system. It requires waivers from the federal government for Medicare and Medicaid, and there is not a single Republican administration or a Democratic administration that would grant a waiver that would turn over Medicare and Medicaid to a state. This is a federal debate, entirely in my view. We can get into all the, like, could we possibly do it on a budgetary basis? Well, it would swamp our budget. I'm not going to even bother with it. Functionally, you need a waiver from the federal government, and a majority of lives in California are now Medicare and Medicaid, so the federal government has to agree to send us all of that federal money and to do a waiver that they will never do, either Democrats or Republicans. So in my estimation, whether you support single payer or don't support single payer, it is a debate for Congress to have. And when there's 60 votes potential in the U.S. Senate to create a federal single payer system, then it's a debate. But right now, it is not a debate at the state. I know there's a lot of headlines. I got a ton of calls yesterday from reporters because of the introduction of the new single payer bill in the state of California. It could get passed by both houses, signed by the governor, and it will not happen.
So a word from your moderator? No.
No, that was the more brief, more direct answer. Yes, thank you. Thank you, Paul.
I agree. It's no. Maybe the little longer version is, there are a lot of policy choices to be made ultimately, there are a lot of choices that are economically viable. And at a macro sense, a tax finance system, which is what we're talking about, a completely tax finance system, is economically viable. So is a completely free market healthcare system, an economically viable system. Ultimately, what gets passed has to also, A, be socially acceptable enough, and to the point Dustin was making, it's certainly not socially acceptable enough, at least at this point, in order to be politically viable along the lines that he was describing. But as a practical matter, by the end of this decade, if I'm not mistaken, something like 75% of all the healthcare dollars in the country will be paid through a tax finance system. So the demographics in the absence of an economic miracle happening that would result in less than 35% of the people who live in the state of California being of economic means, that they're on Medi-Cal, that's an economic problem. That's not a healthcare problem. In the absence of something like that, which I don't think that miracle is not going to happen in the next 10 years, we're for all intents and purposes going to be at an effectively tax finance system in a very short period of time.
This follows a conversation that you were having earlier about the need for more physicians. And would California accepting other states' medical licenses that are pre-approved, would that help the physician shortage?
National licensure is an issue, maybe a bit around the margins, and largely because, unfortunately, the Medical Board of California is incredibly slow in processing applications to be licensed here in the state of California, even if you're previously licensed in another state. CEOs of hospitals call, because we work on this all the time and can't get their months. It's insane. It's crazy. So yeah, it would help in the margins around that. I think it would help certainly for recruitment and ease of having physicians come into the state of California. I think politically it's going to be tough to have that conversation though right now, even though it may ease some of the administrative burdens of physician recruitment and bringing more people to the state, for the simple fact that we're now having the debate in the context of Dobbs, and whether we're going to, as a state of California, subject potentially physicians in this state to a licensing body that may be outside of our borders. And in a Dobbs context, and we haven't really had to deal with it because we only license here in the state of California, but if we were going to a national licensing body, does that mean the state of Indiana could potentially revoke a license of a physician because that license originated in that state? It brings up some interesting questions that go beyond just the administrative burdens and ease of saying, well, if you're licensed by any medical board, you're fine, you can come here and practice in the state of California. What would happen to some of those jurisdictional questions? And we're thinking through those. We're working through those peculiarities, but right now I would say you have to get through that to make it even politically feasible here in the state, because I don't think the state legislature would have any interest in potentially giving up oversight over our physicians and the practice of medicine here in this state, particularly in the context of Dobbs.
Outside of physicians, though, there is a Western regional licensing body for dentists, for nurses. There's been movement, we've seen foreign licensure of nurses, and for some physicians coming from Mexico, having to meet certain requirements here after arrival. There are those types of programs as alternatives, but what he said.
Yeah, and first, come on, medical board, it shouldn't take 6 months to approve a license.
I'm going to combine two questions. The MCO tax looks very promising. Are there any risks that the federal funds on which it relies become unavailable at some point? And I'm going to add to that an additional question, which is, why should voters support the MCO tax?
Well, so I'll take the second one first because it's easier. I think the reasons are obvious. One in 3 Californians on Medi-Cal, and you can say, well, I'm not on Medi-Cal, it doesn't affect me. Well, to Tom's opening comments, go to any emergency department and ask you whether it affects you or not if you're in an emergency and you're trying to get care, you're trying to get it admitted to a hospital, and everything that's wrong in the Medicaid system ends up presenting itself in the emergency department, which affects every single one of us, irrespective of our insurance status. So even if you're being self-interested and you don't care about your fellow Californian, you should think about that. You should think about your family's ability to access care. So everybody should care about it. And to the point beyond that, there's going to be an MCO tax in this state. The only question is whether the dollars from that MCO tax go to healthcare or not. When I went through this at the beginning of all this with the health plans, and they were, they don't like the concept, right, of it, but they all got over it pretty quick because we were investing it back into healthcare. That was the question I posed to them. You're going to be taxed. It's either going to the general fund to build bridges or whatever that people in Sacramento decide they want, or it's going back into healthcare. Those are your only two choices, not whether there's going to be one or not. Now, as it relates to the federal issue, the federal government, in its last approval, put at the very end, well, we're looking at this, whether we're going to continue to allow these taxes or not. They would have to issue rules, and they've been saying looking at it for decades. They haven't done anything about it. We'll continue to monitor it. Is it theoretically possible that they would change it? It is. But I think CMS also likes the money being reinvested back into healthcare because it's being reinvested back into their programs. It's being reinvested into Medicaid, the Center for Medicaid and Medicare Services, not into a way to lever healthcare dollars for things that have nothing to do with healthcare. So frankly, I think what we're doing in this ballot measure makes it more sustainable and more defensible back in DC than the three preceding taxes. We'll continue to push it. I'm pushing other state medical associations to build a similar coalition that we did here. Red states, blue states, because about 17 states have an MCO tax. We're the first to dedicate it to healthcare. I want those other 16 to do the same that we did. So Medicare and Medicaid Services feels part of it, invested in it, not just a thing that it's being used to balance the state budget at their expense.
Last question. What is being done to address the policies that restrict additional sites as the strain on centers, hospitals accommodating the influx of patients is too much?
Hospital
yes.
question, I think?
If it relates, if it relates to hospitals, actually, there's not a regulatory limitation on building a hospital. There's a financial limitation on building a hospital. To build a hospital in California today will cost approximately $4 million per bed. $4 million per bed. When you combine that with what the payment level is in California, the return on the investment for, let's call it, a 160-bed hospital is about 28 years before you get back the money you invested. I don't think, one thing I feel pretty certain predicting, I don't think there will be a for-profit company in the state of California that will be making an investment to build a new hospital. Some of them, and many of them have already exited California long ago, even before those that remain are now going to face the challenge, who don't meet the seismic requirements are going to be facing that question. And it would not surprise me to see some of those institutions either be sold to a not-for-profit organization or closed because of the return on investment question, unless it's a very large for-profit company that has 2 or 3 properties in California. At that point, the economics for the company overall is not that great. But the economics, it's an economic matter now, not a regulatory matter.
So we're going to use that as the final question. I do want to thank all of you for being here tonight. I want to thank Jennifer Heenan, who really took the lead on putting this forum together. And I want to thank our speakers. Thank you, Paul, Dustin, Louise, and Tom. It was a pleasure to be here, pleasure to have this conversation with you and with you. Thank you for coming. Please join us again on April 3rd, where the topic for the Paul Torrens Health Forum will be housing as healthcare. So Paul strongly believed that this dialogue and discussion, this type of event, is what public universities should be in the business of doing, and that UCLA should do more of this. So if you can, please consider making a gift to support the forum so that we can continue to bring this as a free event. And know that we are grateful for your support, whether your support is financial or whether your support is being here tonight, even though for those of us who live in Los Angeles, it's very cold, it might rain, and oh, is that what the alerts were? Apparently, it is raining. So drive safe on your way home, and thank you for being here.